Okay, it looks like we are live. So, hello and welcome to the webinar for the HIV Prevention Reporting Fellowship, sponsored by the Bill and Melinda Gates Foundation and administered by the International Center for Journalists. Again, this webinar is meant to strengthen your applications. So if you are interested in applying for the HIV Prevention Reporting Fellowship, this is where you want to be, because we're going to talk a little bit about VMMC, voluntary medical male circumcision, and HIV prevention reporting. So we will not be discussing the details of the program itself, but we'll be focusing primarily on your application and your story proposal. If you have questions about the program itself, you can email either myself, Lindsay Wagert, a program manager here at ICFJ, or Joanna Carrillo, a program director at ICFJ as well, and we'll be working on the program. So you can email us after the webinar if you have specific questions about the program, dates, things like that. But again, this is meant to answer your questions about your applications, about your story proposals, and about VMMC. Our emails will be made available at the end of the webinar, but right now we're going to go over a little bit about the application process and who's eligible to apply. So let me just pull up our tips here. So who can apply to this fellowship? Journalists from Botswana, Ethiopia, Kenya, Lesotho, Malawi, Mozambique, Namibia, Rwanda, South Africa, Swaziland, Tanzania, Uganda, Zambia, and Zimbabwe are eligible. Freelancers and journalists from large media and small community media are eligible to apply. Those with strong detailed story proposals on VMMC will especially be considered. Again, this is why this webinar should be helpful today. And applications are due on October 19th. And taking a quick look at the application itself, you'll notice that you'll need to provide any contact information, of course, your name, last name. And the main focus of the application will, again, be on the story proposal. This fellowship is meant to help you really report on VMMC and HIV prevention. And so we're looking for strong story proposals, ideas that you'll be following throughout the fellowship and that you'll be reporting on as you take part. So applicants to this fellowship are required to submit a preliminary project proposal outlining a research, reporting, or writing assignment to be undertaken throughout the program itself. The story or stories should relate to voluntary medical male circumcision, VMMC, the main topic you will pursue through the fellowship. In addition to explaining the topics or themes to be addressed, your proposal should outline the practical and logistical steps that will be required to complete reporting. So you'll see on the application that we have a little bit more information about what will be required. You'll need to upload a document detailing your story proposal and provide a timeline of how you would go about reporting the story. And again, if you have questions after today, you can email myself, Lindsay Wagert, and Joanna Carrillo at icfj.org. And we'll make this slide available at the end of the webinar. So what I wanted to do next is to introduce our main speakers for today's discussion. I'll first introduce Chris Conti. He is a former Wall Street Journal reporter and editor, an independent journalist, an editor and media consultant with expertise in news and feature journalism, development, and social policy. And we've brought him on as our lead expert and trainer on health reporting for this English-based webinar. Again, if you're interested in taking part in the Portuguese-based webinar for Portuguese speakers, that will be taking place tomorrow. I'd also like to introduce Dr. Josephine Alcere Darko, who's the Chief Technical Officer and physician at the Center for HIV and AIDS Prevention Studies, CHAPS, with a medical degree from the Medical University of South Africa, and she's currently completing her master's in public health. We're very excited to have Josephine join us today. She's actually joining us from abroad, and so we will have her here to answer your questions on VMMC and HIV prevention. So without any further ado, I actually want to turn it over to Dr. Josephine, who can give us a little bit more of an overview on VMMC and HIV prevention. So Josephine, I will turn it over to you. I'm not sure if you might have to unmute your microphone.
Okay. You can hear me, right?
Yeah.
Okay. Thank you, Lindsay, and thank you very much for having me on the webinar. All right, so I'm going to go over to my slides now. Okay, so basically what we're going to talk about, as Lindsay already mentioned, is VMMC, just a brief overview and issues about reporting. So the next slide actually covers VMMC in a very simplified manner. Just to give you a little background about how medical male circumcision started, it was actually based on the 3 randomized controlled trials that were done in Kenya, Uganda, and South Africa. That proved that MMC reduces HIV infection risk by about 60%. So based on that finding, WHO recommended to 13 African countries, which I think most of the journalists are actually from those countries, as an efficacious HIV prevention strategy. And they also recommended that if they have a low MMC rate, they need to scale up to reduce the number of HIV incidences. So just basically explaining what medical male circumcision is to those who don't really know much about it. The basic definition is just the surgical or device-based removal of the foreskin. And usually the question comes out about how does it reduce the risk of HIV infection? And the answer to that is that the part that we concentrate on, which is the inner part of the foreskin or the inner foreskin, is the area that predisposes the man to getting HIV. So if you circumcise the client or you circumcise the males and remove this part of the inner foreskin, you reduce the number of immune cells that are numerous on that part of the foreskin. And those are actually called Langerhans cells. And they facilitate the infection by HIV. And the second reason why MMC reduces HIV is that it also reduces the number of blood vessels on the foreskin, because if you remove this part of the foreskin, you remove most of the blood vessels. And the third reason is that this part of the foreskin is also prone to tearing because it's very soft and delicate. So if it tears, then the virus can actually enter easily. Okay, so this is just a brief overview of MMC, and I'm sure if you have any other questions, we can always answer at a later stage. Okay, now just to go to our base or our reason for the webinar, it's just introducing the reporting part. I know MMC in most countries is often misunderstood and sometimes misrepresented based on several myths that exist in our communities. Especially like a country like South Africa, there's a very huge cultural connotation, and sometimes the risk behavior that is associated to that. And there is also the link to HIV that is not very well understood in some communities, because most people don't understand how it reduces the HIV risk. And so that has come up as a bit of a confusion in the reporting and in the understanding of the general or within the general public, and it causes quite a lot of challenges to the program implementers. Now the biggest shortcomings of media coverage, if we can look at for something that our journalists or potential applicants can look into, would be the cost of media coverage. So for MMC, there's obviously for media to make an advert, for example, there's a lot of cost attached to that. So that always comes into a lot of countries' strategies to cover MMC, in media. Okay, so if we could get into getting it out without so much cost attached to it, that will really probably help. And the lack of sense of urgency in a lot of countries, because it's an elective procedure, there's HIV attached to it, but the understanding is not really there. Okay. And the political will also by policymakers. Like I mentioned already, there are a lot of cultural barriers that affect that. There are some countries that prefer traditional way of circumcising, and so it really affects the coverage. And the fear of victimizing traditional circumcisers also comes in. And the other shortcoming would be the lack of understanding of some of the concepts by reporters themselves or the journalists. And this opportunity would really, really help with equipping our journalists with the information that's required or needed to report efficiently on MMC. Now, the other thing that we can talk about is the current focus shift of, from HIV prevention to HIV treatment, which is currently our biggest concern as experts, based on the 1990 initiative. And I'll explain a little bit of that when I get to the other slide. Now, going a little bit on what is new and big in MMC that we could probably look at covering, in reporting, as if you go to a lot of countries that have the seasonality issue, you'll find that our move model concept is really helping, because you get hundreds of males or clients, as we call them, coming for circumcision on one day. And that model that we use to, do a high volume of circumcisions in a short space of time really helps us cover a huge amount of circumcisions in a short time during those peak seasons. And I think that's something that could be a positive for reporting, that could encourage even policymakers as well as the public in general to really see how great the models that are used in several countries is impacting on HIV prevention based on the numbers that we can do at a time. The other thing that I think is new and big that we could look at is efforts to address seasonality. I mean, recently a study was done, or not really a study, but a pilot was done in Tanzania, where they tried to limit the seasonality issue by providing the services only when it's the low season period. So these are kind of things that we can really build on as reporters. The other issue that I think is new would be the device-based male circumcisions. I know in a country like Rwanda, prepex is very prevalent and is very accepted. So those are kind of the kind of things that we could look at reporting and the benefits thereof. The other thing that I think is good for these guys would be the early infant male circumcisions in countries that are conducting the pilot studies. I mean, it is clear that neonatal or early infant circumcision does have a strong impact on the HIV prevalence in a lot of countries. So that is something that we can actually also look at. The next slide speaks about the barriers and the strategies thereof to address MMC rate increase. So the barriers that we're currently facing are cultural beliefs and misconceptions, like I mentioned already, lack of understanding of the benefits by the general public, as already mentioned as well, and poor coverage in some countries. I mean, some countries just don't have the resources, because if you want to scale up and you need to do a high number of male circumcisions, you need a number of resources, from human resource to basically consumables, for example. And the lack of political will, because the urgency is not really understood, and possibly the negative peer influences that occurs in our communities. Now, what are some of the strategies that we're using to address this kind of MMC rate increase? We're using a lot of mobile clinics in most countries that actually takes the service to the people. Obviously, some people have challenges with accessibility, and if you take it to the people, you really provide them with a service. And the other strategy that we're using is partnership with general practitioners, or as we call them in some countries, not necessarily physicians, but non-specialists who are also providing medical services in the communities, and granting them the ability or partnering with them to also provide MMC will increase the accessibility issue and also reach the middle and upper class. The other strategy that is currently being used in some countries is social mobilization and mass media coverage. So for us, we, especially in South Africa, we're actually looking now at mass media coverage and social mobilization as our main, but actually more social mobilization, because we've tried quite a lot of mass media coverage already. And the last strategy that is currently used also is increase in trained field workers, so you have marketers or salespersons that are in the communities, basically selling the idea and encouraging people to take up the service. That is all I have currently. I will hand it over to Chris to ask more questions. Okay, I've stopped the screen share.
I'm on? Oh, hello, everybody. Obviously, I'm not really used to this technology. Either that or I haven't wakened up yet. So thank you, Josephine, for that introduction to the issue. Actually, before I start asking questions, my assignment was to talk a little bit about what we're looking for in a story proposal. And in a sense, really, I'm going to tell you what any editor is looking for in a story proposal. But this is quite an opportunity for journalists, because typically, we get our story assignments at 10 o'clock in the morning, and we have to have the stories done by 2 in the afternoon. But this is actually an opportunity to do stories the way most of us really wish we could always do stories, which is with a lot of care, a lot of forethought, and a lot of work to actually produce the story. But I should say that also creates a burden for us. Creating a good story proposal is a lot of work. It's really as much work as sometimes you do producing a whole story. So I have some slides of my own. They're very simple. But I've basically created 6 points that I think are the keys to creating a good story proposal. And there are the first 3. I hope you can see them.
Yeah, I can.
Good. First, and this is almost so obvious it doesn't need to be said, but it's amazing how often reporters don't actually think about it. Is you have to really create a very clear and concise theme for your story. As an editor, I never was interested, and as a reporter, I had many editors who turned me away when I came to them and said, I want to do a story about X, or I want to do an in-depth story on, voluntary medical male circumcision. That's just too vague, too general, and as an editor, I have no confidence that that's going to produce a meaningful and interesting story. So, first lesson here is to be very specific. Don't tell me you're going to do an in-depth look at VMMC. Tell me, why is the public health system falling short in achieving its objectives in this regard? If that's true, that may not be true. I just use that as an example to show that I want something that's more specific and more challenging. I also I don't want stories about intentions. One of the things we do all the time is write, the Ministry of Health has set a goal of X percentage of men should be circumcised by, you pick the date, 2018. Intentions really aren't worth very much to me. I really want to know what's actually happening. Second, so think very carefully about your theme, and what can you say that is really going to be interesting and important. And test your theme. There are a couple of ways to test it. One is what I call the editor test. And basically, editors are busy and they want to know the bottom line. So ask yourself, can you summarize your story idea in a couple of sentences? Or can you imagine a headline for it? If you can't, the chances are the story may not be focused enough to produce a convincing story. Also, there's a broader kind of test, which I call the reality test. And that really is just show me in your proposal that you have done enough reporting that you're confident that there is really a story here. If you decide that the public health system is falling short in achieving its objectives, show me enough. You don't have to prove the case absolutely, but show me enough evidence that I'm convinced that that really is a valid story that's going to hold up after you spend a lot of time working on it. So that's my first point. Second, we are in the news business. So any story proposal that I see really should have something new to it. Tell me something new that I don't know already. One of the standard ways of doing this is to try to look at, especially when you're dealing with a story that in a sense is an old story now. Most people have heard about VMMC, I think, many have at least, and they're not going to be too motivated to read another story about it unless you can show them something new that they don't already know. So one of the common approaches to that is try to look for a different perspective. Don't just talk to the public affairs spokesman at the Ministry of Health or the advocacy organization, which you probably already have talked to a lot, but go out in the field and talk to people who are actually doing counseling. Talk to healthcare providers and say, what are you finding when you talk about this issue with men? Talk to women. There are, I know, some experiences that suggest that getting women enlisted in the campaign to promote this is a very effective device. So talk to women and get their take on it. I think a lot of men probably are very concerned and interested in what women would say about that subject. Look at people who are involved in other aspects of HIV/AIDS. How about people who are really focused on treatment as a form of prevention? What do they say about voluntary medical male circumcision, and where does it fit into the whole effort? This is really a story about behavior change communication, so I would recommend that you talk to people who are experts in that subject. What do we know from past experiences with behavior change modification? What works? What doesn't work? And try to be a little bit creative too. Some of the best experts in behavior change communication are not in public health, but they're in advertising. I sometimes think if public health experts were as effective as people who advertise cigarettes and liquor, we'd have a much healthier society today. So why don't you ask an advertising expert, what would you do if you wanted to sell this issue to the public? I think that could be a very interesting story, and it's a different perspective. Obviously, religious leaders are very important in molding public opinion, so you want to enlist their views about it. Also, we tend not to talk about ourselves, and that's probably a good thing most of the time. But what about journalists and their experiences doing stories? Maybe a journalist could tell you a lot about a story that worked, a story that didn't work, why it's hard to sell stories to editors as well as to the general public. So again, that's just another kind of perspective. And I won't belabor some of the other points here, but obviously when you form a story, sometimes just giving people the context that they don't understand is very relevant. Telling how an issue is playing out in your local region and how your local area, your service area, compares to others where this issue is being fought out. That also can be a very relevant, different perspective. And finally, I'd say, I didn't put it on the slide, but you should question authority. Anytime somebody gives you a press release, I think the first question you should ask yourself is, why are they doing this? So I think it's wonderful that the Bill and Melinda Gates are funding this fellowship program, but ask yourself why. What are their concerns? What made them choose this issue to promote at this time? And what made them choose journalists as a vehicle for promoting it? I think there's some interesting stories to be told there. Third point in formulating a story proposal is to explain to your editor why this story is important. You know, a journalism trainer who I learned an awful lot from used to tell all the time, beginning, middle, and end of all of his training sessions, was he wants stories to answer two basic questions: so what, and who cares? So tell me why I should pick this story over hundreds of other story possibilities that I'm looking at every day. And the answers can be varied. Sometimes it's important because policymakers aren't on board. Maybe policymakers don't understand all the issues. You know, maybe policymakers don't understand the cost implications. Jennifer referred to the costs of producing stories, but policymakers, Josephine, I'm sorry. I said it, as I said, it is early. Sorry, Josephine.
It's okay.
But you know, sometimes it's really worth pointing out to policymakers the cost-benefit ratio when it comes to a preventive strategy like circumcision, as opposed to lifelong treatment for people who are HIV positive. And obviously, we also need to explore what the public knows and doesn't know. And when you can identify clear gaps in public's knowledge, then it's much easier to justify, to me, a story that's going to say, you know, I'm going to do a story explaining things that aren't understood, or rebutting common myths about circumcision or HIV/AIDS in general. A fourth point when you do a story proposal is I want to see people in the story. That's really what makes people read stories. Very few people read newspapers, watch television, or listen to the radio because they want to think in depth about abstract issues. They do it because they want to see what other people are thinking and saying and doing. So I want to see ordinary people and see how they're dealing with this issue and how they're affected by it. But let me remind you that experts are ordinary people too. So I'd love to see more stories that go behind the scenes and talk to the experts like Josephine and tell me who she is as a person and what are her real personal concerns when she thinks about this issue. Personal concerns not about herself maybe or her family, but her own concerns about whether she's achieving what she's set out as her life's work. So again, think seriously about putting people in your stories. Lindsay mentioned that one of the things that we want to know when you apply and when you make your applications is how are you going to get the story? And there's a very obvious reason for that. You've got to be practical. Nobody's going to approve a story. No editor is going to approve a story. And I don't think anybody who's judging proposals for this fellowship will approve a story if it's just not something that you can conceive, that you can achieve. So, you know, it may be wonderful to propose a story that would involve you traveling all around the world and exploring medical male circumcision as it plays out in the four corners of the world. But let's be practical. That's not a story that's likely to be approved. And finally, in a proposal, tell me why the story is going to be a good story. And I put story in caps because we have to remember that what makes us as journalists different from advocates is that we're in the business of telling stories. And advocates want to use that skill because they know it is very powerful. As an editor, I may think a story is really important, and in some cases, its importance will trump everything else. But what is really going to motivate me is whether the story is good. So do you have an interesting setting to go to? Is there an interesting plot? Are there interesting characters? Maybe you can build your story around a profile of somebody who you find is just fascinating. And you know, we all know this, but it's worth mentioning that if you can find things happening, if you can find conflict, and if the story is building to some kind of a climax, all of those things are what draw readers in and keep them there. And if I'm an editor and I'm deciding what story to approve and what not to approve, I want to see you tell me, hey, not only is this important, not only do I have all these other things you asked for, but hey, it's just a good story. So those are my my guidelines for how to produce a good proposal. Thank you. Okay, so we do already have some questions that are coming in, and a number of them go to issues that are really technical medical issues.
Okay.
So I think to the extent that these are questions people have, that suggests that maybe part of our job really is to do some more basic explainers to people. So here's a question from David Nyaji from, I believe, Kenya. Yes. He mentions that the International AIDS Vaccine Initiative has confirmed that search for an HIV vaccine is showing early promise. In light of this, do we see preventive measures such as VMMC losing international support? If science succeeds in developing an HIV vaccine, will voluntary medical male circumcision be a moot issue?
Okay, so that obviously would come into, at the end of the day, are countries able to offer the vaccine? Okay, so it will be great for vaccines to be available, but we all know that not all countries will be up to speed to make sure that everybody has access to the vaccines, etc. Due to lack of resources, lack of political will, etc. So HIV prevention using MMC will still be a focus because the time lapse or the time frame between getting the vaccines into many systems in countries would take years. And, eventually we probably would not need as much of medical male circumcisions as we do now, but I think that there will still be a need for a long time. So it is valid that it would be that concern that MMC would probably, slowly phase out. But I think that there will be a lot of countries that may not still have access, and it probably may not be free from the beginning, like other vaccines. So it may not be accessible to a lot of countries. But circumcision would still be accessible because it will still already be a public health intervention. So that's my answer.
Can I ask you just to venture your best estimate about how far away we are from actually even having a vaccine?
Oh, I think we are years away, if not 10 years.
So one thing a journalist could do quite, I think very productively would be just to point out what will be the cost in human suffering, but also in in treatment, cost to the economy from lost productivity, for all of per year, for all the years, 10 years or whatever, it take to produce an HIV vaccine.
If at all. I mean, as far as I'm concerned, if you understand how the virus works, as most of us do, it is such a clever virus that for them to actually, I know it's a good initiative and it's still in the process of getting there, but for them to actually get the vaccine, it is many years to come. So like you're saying, Chris, it's very important that we actually really take that time frame into consideration and do some modeling going forward. So the vaccines are far in the future. So we probably need to concentrate on the HIV prevention now.
I'll just make one other comment. I think it is a very interesting story how vaccine research occurs. Maybe a good case in point and a parallel to what you're talking about with HIV is the search for a malaria vaccine, which how long have we been looking for that without producing an effective one?
Getting there. Yep. So it's way ahead of us. So we probably should not even look at it in terms of journalism or reporting yet, because it's a challenge. It's a huge challenge.
Okay, let me shift gears. I actually promised a minute ago that some of the people who have contacted us have been asking some pretty technical questions.
Mm-hmm.
And I'm going to ask two here at the same time. One person who wrote in asked us, why is it that voluntary medical circumcision only prevents 60%, or is only effective in 60% of the cases? What's the
Mm-hmm.
clinical explanation for the remaining 40%? And related to that very closely is another question we got from somebody who said, why is it that the foreskin is a particular issue? Can't the virus get into a man system, or actually come out of a man system via the urethra, or other parts of his anatomy besides the foreskin?
Okay, great question. All right, so the first part, which is why the 60%, I think we probably have to go back to how circumcision is done. All right, so circumcision, when you circumcise a person, you don't remove all of the foreskin, contrary to, some belief. You always leave behind a quarter of that inner foreskin that is the area that HIV acquisition occurs. So that quarter is actually the part that contributes to the 40% that we can't really prevent, or, because we still have to leave behind that amount of foreskin to be able to close the wound. So, if we could remove all the foreskin, then MMC could probably be 90% preventative. But because we leave behind that inner foreskin, which is, I mentioned already, is the area that the virus usually permeates, is the whole reason why circumcision could never be 100% preventative. Now, going to the second reason of why the foreskin is an issue and not the other anatomical areas like the urethra, I must tell you that some studies have looked at the urethra as a receptor for the virus, but up to now, no study has actually proven that there are receptors within the urethra that can transmit the virus. So for now, we still on the foreskin. Okay, so the reason why the foreskin is still the issue is based on the reasons that I gave when I did the VMMC overview. The foreskin is where the Langerhans cells are, which are the immune cells that attract the virus, and that's where the blood vessels are, the numerous blood vessels are. And the other reason is because of the tearing that the inner foreskin usually undergoes. So that's the main reason why the foreskin is still the issue and nowhere else, because you hardly get the urethra breaking because it's not exposed, but it's the foreskin that is exposed during sexual intercourse.
Okay, thank you. This is a related question from Niamudzai, I may have pronounced that wrong, probably, Kakore from Zimbabwe, who asks, how can African medical male practitioners help in the promotion of voluntary medical male circumcision without encouraging the belief that after circumcision men can engage in sex without protection?
Okay, so it again goes down to the 40% foreskin left behind. So if we keep preaching, if we want to put it that way, that it's 60% because we still leave behind some foreskin, which can still predispose you to getting the virus. That actually MMC is more of an insurance policy in a way. People should get that message. So usually when I do training, because I train most of the time, the thing that I always tell our colleagues is that do not preach total prevention for MMC, because that is not what it is. So let us be frank and honest about what the risks are, even after circumcision. And I think that is what some studies have actually found, that when the men come through the clinics and they get the risk reduction counseling attached to the actual medical male circumcision, it changes their way of thinking a little bit. So that message really needs to be there to avoid promoting that MMC is doesn't have any link to HIV or HIV acquisition in any way.
Well, thank you. Kokori also mentioned that in Harare, the capital of Zimbabwe, there were 45,000 cases of sexually transmitted infections in 2014. And I'm wondering, what is the evidence about the effectiveness of circumcision in reducing the risk of other kinds of sexually transmitted infections besides HIV?
Okay, so the studies that have been done, even by us in Uganda and Kenya, the only protection that circumcision has been found to have is on ulcers, so ulcerative STIs. And that is mainly because when you circumcise somebody, you actually remove the surface area or the area that the ulcers would actually occur. So if you remove the foreskin, you've decreased their area for the transmission or the acquisition of the ulcer. But no effect has been found on discharges. So actually the 45,000 number that he's referring to would probably be the discharge, the urethral discharge, or the STIs that causes a urethral discharge, which has no link to medical male circumcision at all, because we've got nothing to do with the urethra. Okay, and again we go back to the risk reduction counseling. So if people still get circumcised and we still have such a high number of sexually transmitted infections, then there's a gap between circumcision and actually getting people to change behavior. Okay, so that is probably where we need to really go back and do our homework, to reduce the number of STIs in the era of medical male circumcision.
Okay, thank you. I have another question, also from the same questioner, who points out that in Africa, many church prophets have mushroomed in recent years after praying for HIV-infected patients, and actually are advising HIV-infected patients that they should stop antiretroviral therapy because these prophets claim that they can be healed through prayer. How do you deal with messages like that conflict with the message you're trying to get across?
Oh, that's a tough one, because we all know belief to human beings is religion to human beings is so strong that it's very difficult to permeate. But I think at the end of the day, it's up to us as medical experts to ensure that the message is out there clearly, and ensure that people understand that the link between our spiritual being and our physical being is not always as simple or as transparent as we would like it to be. So that question, Chris, I'll tell you that even in our homes we struggle with belief, so religious belief. So it's a very, very tough platform for as physicians to deal with, because if a patient decides that he goes to church and he's been prayed for and he's not going to take the medication, or he's not going to get circumcised or not use a condom because he feels he's immune or he's been prayed for, there is really so much that you can do as a physical being, if we can put it that way. So again, my summary to that question would be just making sure we have our stand, and as medical experts, and giving out the messages according to the scope of our knowledge, and making sure that people understand that not taking your treatment has these consequences, and if you are willing to get those complications, then you go ahead.
I believe I've heard that actually there are in Africa a small number of people, I think maybe from my country and maybe other countries outside of Africa, who actually are advocates against circumcision. Have you encountered that? And again, one of the challenges journalists always have in situations like this is if we cover them, are we increasing their credibility and exposure more than they deserve? Or is there something to be gained by really putting them under the public scrutiny the way we put everybody else we cover under public scrutiny?
Luckily in South Africa, because of the cultural affiliations with circumcision, we don't really have that kind of challenge, because South Africa loves circumcision and they actually love traditional circumcision. It's part of their culture. So we don't really have that challenge. But what I would say though is that I would advise us to not blow or to not advertise them much, because I feel that getting their voice out there would actually potentially change or influence other people who may have not thought otherwise about circumcision, So giving them that platform could probably only diminish or influence other people negatively. That's my take, because I know there are a lot of people out there who, especially in your country, like you said, who are against circumcision. And for us in Africa, because we are so in tune with our beliefs and our culture, if we get the negative aspects to it, we might encounter a lot of challenges.
Oh, thank you. I should add that I believe it's true that the U.S. has one of the highest rates of circumcision in the world, or at least it did. It has traditionally. So just in the interest of balance, I'll mention that fact. Okay. We have a question, a different kind of question that actually, Josephine, may give you a chance to catch your breath, because it goes to the issue of story proposals. It's from James Thambo Malalekwa in South Africa, who asks, are proposals supposed to be in the form of stories? If yes, how long can a story be, and how many comments must we get? I guess my answer to that question, just from my own experience, is that it doesn't hurt if a story proposal comes really showing me what the story is going to look like. If it has a story proposal that has a catchy lead, that has a good paragraph that summarizes what's the gist of the story and tells me what's important about it and all the other things I mentioned, typically you can do all of that. You should be able to do all of that, I think, in about a page, and it doesn't hurt. But also, sometimes you want to talk directly to the editor in a way that you wouldn't if you were actually writing a story. I guess I would write it as if you were writing a story, but I wouldn't feel that the proposal should actually be a story. As far as length and other guidelines, I'd like to actually ask Lindsay if she can join the conversation on that point.
Sure. So ultimately, again, as Chris said, the proposal can look like a story as long as you addressed some of the other questions that we laid out in that application. And so, again, talking about your publishing plan, as Chris reiterated, talking about how you would report the story. So obviously, if you're presenting just a story, that's not going to answer all of those questions. And so we really need to know that. In terms of the length, all of those details are ultimately found on the application page. And so, as Chris mentioned, if you can provide about a page of information for your proposal, I mean, we're not looking for 8-page proposals, but we are looking for something that gets your story across in a concise way, but also addresses all of our questions. So that's my answer to that.
Okay. So the lines are open, as they say in call-in radio programs, and we're available for any other questions people have. Perhaps I should try to keep things going just by asking a couple of my own. Josephine, I think probably my guess is a lot of people don't really know what the MOVE model, which you mentioned, is. And I'm pretty confident that's the case because I'll have to admit I don't know what it is. I wonder if you could just elaborate on what it is and why is it such a positive development in your view?
Okay. All right. So the MOVE model is actually a model that we was designed by our company when we started, after the trial, when we started service delivery or provision of MMC. So what it entails is actually ensuring that you do a high amount of circumcisions in a short space of time, like I mentioned. Now it has three principles that we designed it based on. And the first principle is actually making sure that you use efficient surgical techniques. So basically, using surgical techniques that will shorten the surgical time, like choosing a faster method of circumcision, okay? Using a machine to stop bleeding, for example, rather than tying the blood vessels, all those save time. The second principle that comes into the model, was task sharing. So you share the task. So what that entails is that in a clinic that provides medical male circumcision, instead of one person doing the entire procedure, you divide the tasks. Okay, so that again, the more the hands or the more hands you have, the faster you can actually complete the procedure and the more you can do. Now, the third principle that comes into this model is task shifting. So basically what that entails again is making sure that a lot more professionals are trained to do the procedure. So like, for example, in our context, doctors are no longer the only people that can actually circumcise. We've got a middle cadre that is actually called clinical associates that can actually circumcise. So, if there's a shortage of doctors, you can always use another level of profession, for example. Okay, so all these three principles, actually, when they come together, and also the setting of the clinic itself. So you'll see, like in some of our clinics or in other countries, as opposed to having a theater where one bed does one procedure at a time, you have a lot of beds in one room, separated by screens or bed or curtains, that, basically having a lot of procedures done at the same time. Okay, so that is basically what the MOVE model stands for. And as it says in the name, it's a MOVE model. So you'll see that in the clinics that apply this model, there's a move. So, we move throughout the procedure or the clinic, to make sure that a lot of circumcisions are done at once. Okay, that's the long and short of it. I hope you understand.
I think I do, at least basically. The moving is being done by practitioners.
Yep.
How much of the issue is what the practitioners are doing as opposed to public acceptance?
Okay, so you mean in terms of technical or just
no,
the actual outcome?
When you look at the problem, to what extent do you think that the challenge is in the practitioner community? They're either not doing things right or they're not fully on board, as opposed to just public acceptance, men voluntarily saying, hey, I should do this, and doing it.
Oh, okay. So I think for now, because we've got a reputation that actually encourages the public to accept the practice. So, you're not getting a lot of people dying from the actual procedure, for example, So for us, especially in our context, for example, we are actually competing a lot with the traditional guys who every year have the deaths that are reported in the media, so that already gives them that negative coverage. And then because we don't have any of that, that actually supports our program, and that encourages the people to really come and take up the service. So in terms of the technicality part, I can safely say they trust us to a large extent to allow us to actually come for the service. They trust us.
Okay. Well, I feel like we're just warming up, and isn't it always? We're done. We're out of time, but I do hope that our conversation has stirred people's curiosity. I find that you know, every time you talk, I think of about 3 or 4 more questions I'd like to ask. You know, now we're in the process of really starting to think really hard about stories, and so this is a good time for people to think about you know, what questions they have, what questions they think need to be answered, and as I said before, spend a little bit of time talking to you know, people like Josephine, who can really you know, help us come up with a really powerful set of stories. I can't wait to see what you come up with, and I can't wait to work with you on it. So I will now hand the floor back over to Lindsay.
Okay, thanks, Chris.
Great. Well, thank you so much, Chris and Josephine, for joining us, and thank you to all of the viewers for joining us as well. We had some fantastic questions coming on our Google Plus page and on our YouTube comments. And I did want to mention that if you want to revisit this conversation or share it with your friends or colleagues, the video will be made available on ICFJ's YouTube page. We'll make sure that link is available on the program page itself, so you can distribute that and revisit it. I know there's a lot of information, so you might want to reference some of the PowerPoints and things like that. I did also want to mention that our October 19th deadline is swiftly approaching. So if you have questions about VMMC, HIV prevention, or the program itself, please refer them to myself, Lindsay Wagert at ICFJ.org, and Joanna Carrillo. I'm going to put our email addresses up on the screen again so you can take a look at those. And ultimately, if you have questions for our experts as well, you can direct them to us. This is for after the webinar ends. I know we had some great questions coming along on the YouTube channel and the Google Plus page, but if you have follow-up questions about the topic and about the program itself, please send them to us. And our emails are up on the screen now, and they're also available on the program page. So yes, I just wanted to thank everyone for joining us again, and let me actually just pull up our screen, and thank Josephine and Chris for joining us. It's been fantastic and very informative. So.
Thank you for having me.
Of course.
Thank you, and goodbye, Josephine.
All right, bye.
Great. Thanks so much.
Thank you. I enjoyed my time. Thank you. Bye.
Great. Okay.